want to move from induction chemotherapy and talk about some of the data that came out at this year's ASCO meeting around how to refine chemotherapy radiation and where we're going forward, perhaps revisiting some standards. And Josh, tell us some of the data that excited you out of this year's ASCO meeting.
So the one that excited me the most surrounded cisplatin dosing. So we've discussed about cisplatin 100 milligrams per meter squared bolus dosing. That's a big dose of cisplatin. The toxicity is substantial. And so what many people have been doing is they've been using a weekly dose of cisplatin along with radiation, and we're doing that with scant data, I think I could say generously.
Scant to negative.
Scant to non-existent. I mean,
Scant to negative.
there might be
Not
some
non-existent,
data.
but to
I
negative.
think under the table there's some
We had
data.
multiple phase 2s
So,
with 20
yeah.
and 30.
There's phase 2 data in single-arm studies showing that it's effective. But when you put those up against phase 3 randomized studies, it's really hard. But the problem is when you have a patient who has significant significant comorbidity going in, and you're a little hesitant about giving them 100 milligrams per meter squared cisplatin along with radiation, I think that some of that data regarding weekly dosing, usually at 40 milligrams per meter squared, is quite appealing. Especially given the fact that the underlying mechanism of action purported for cisplatin with radiation is as a radiation sensitizer. So it makes biologic sense even to spread out the cisplatin to maybe have it in the system throughout the radiation. Here I'm obviously waving hands a little bit, but there's a reason to think this might work.
Figuratively and literally.
Exactly. So there were 2 studies at ASCO this year that looked at this with trials. So I want to talk first about one done in China in nasopharyngeal cancer. And in that study, they randomized patients to weekly 40 milligrams per meter squared of cisplatin or 2 doses of high-dose cisplatin, 100 milligrams per meter squared, which is not the standard of care traditionally. It's usually 3 doses. In any case, they found that the overall survival, loco-regional control, any cancer outcome you look at was identical between the 2 groups. What was interesting about that study, though, was that they found that the toxicity was greater for weekly dosing. Now, this was an abstract, so I don't know how frequently they checked CBCs in the every 3-week dosing. So they noticed more cytopenias in the weekly dosing. I'm wondering if there were more CBCs done in that group as well. But I don't know at this juncture. And that study was done in nasopharyngeal cancer, again in China, so EBV, different patient population. The other study which was done in India, which purported to look at chemoradiation just in general in head and neck. But over 90% of the patients on that study were receiving adjuvant chemoradiotherapy for oral cavity cancer. The reason why that's relevant and why I specified that the study was done in India is that the exposures that lead to oral cavity cancers in India are quite different than the exposures that occur in the United States. Specifically, the use of betel nuts and smokeless tobacco is at a much higher rate in that population. They found that while the overall survival was the same between high dose and weekly dosing, which by the way used 30 milligrams, not 40 milligrams per meter squared, they found that the loco-regional control was significantly worse with the weekly dosing. Where does this leave me in terms of the use of weekly dosing? I'm just as confused as when I walked in. And so I think that there are significant limitations to both of these studies, but it's really hard to imagine a robust phase 3 study that's really going to answer this question. So I think that efforts to look at retrospective large series would be an appropriate next step to really get at this from an American US population.
Although those series may contain the bias that we all give the 100 when we can and we give the 40 when we don't think we can give the 100.
The other thing to note is that a lot of the US is not using 40 as their standard. I agree with both of your comment that when weekly is used, it should be the preferred regimen. But having spoken to a lot of community docs, it's not always. It's often, I think more often the 30 that they're using, which is a legitimately de-intensified regimen for better and for worse.
So Jared, you'd advocate, if you're going to use weekly, use the 40.
Yeah, so to my mind, if you have a patient whose risk is high enough that you really think you need chemotherapy added in, your main goal in using weekly is not necessarily to de-escalate, but rather to have only 1 week of drug stuck in the patient if you start to get into trouble, so that you can adjust dose or bail as the patient needs on a weekly basis instead of an every 3-week basis, and you see them a lot more and provide more supportive care.
And the peak dose may be somewhat tied to ototoxicity and nephrotoxicity. So for the person who's got the borderline audiogram or the hypertensive who's on 3 drugs.
But I'm not advocating a de-escalation, just a breaking up. Yeah.
But so one of the interesting things about the Neurona presentation was this implication, again, that high dose Q3 week was not as toxic as the weekly schedule. But it came out in the presentation that they had provided significantly more supportive care for the 100 because they were so concerned that it wouldn't be feasible. So more hospitalization for hydration and so forth.
In the 100, the adverse events, I believe, were higher than they were in weekly, which is what I'd expect from a clinical perspective, but they were not
unmanageable.
And they were different.
Yes, they were different.
So Barbara, I would completely agree with you. It does look like one thing that is definitely coming out in terms of toxicity is that the high dose cisplatin does have higher rates of ototoxicity and likely higher rates of nephrotoxicity because that's related to Cmax of the drug, and you're going to get a higher Cmax with 100 milligram per meter squared. I'll tell you my take on the 2 studies that you were talking about. One is that 40 per meter squared to me seems to be actually more toxic than the every 3 week without a significant signal that it's more efficacious, while the 30 milligram per meter squared, as you alluded to, Jared, appears to be less efficacious in a patient that we're trying to cure. Maybe that's not the optimal dose. And to me, personally, I came out of the meeting thinking that this was an advocacy for the every 3 week 100 milligram per meter squared. That's a bit of editorializing.